Today we're going to talk about respiratory failure. The core function of respiration, or the function of breathing, is we move air from the outside into the lungs, primarily so that we can bring in oxygen that we need and to throw out carbon dioxide, which is produced as a result of metabolism. So we bring in oxygen and throw out carbon dioxide. These are the core functions of respiration. Now, respiration does this by two processes. The first process is ventilation, which is the movement of air into the lungs and out of the lungs. And this we can see as breathing in and breathing out. When we breathe in, it is a process guided by muscles. We breathe in and the muscles will act to expand the chest, and therefore air is sucked in. On the other hand, we breathe out as a passive process. The muscles relax, gravity takes over, the space becomes less, and this air is gradually pushed out through the airway. Now, as we breathe in and out, that air that we breathe in contains a lot of oxygen, and the air that we breathe out now contains much more carbon dioxide. The second process is at the microscopic level, and it occurs within the structure of the lungs, and that is a process called oxygenation. And oxygenation is how the oxygen moves from the air that we breathe in and goes through and enters into the blood that will be carried to the rest of the body. This process occurs at each and every of all the millions of alveoli that are in our lungs. Each alveoli will move oxygen from the alveoli into the blood, then it goes to the rest of the body, and will bring carbon dioxide that's brought from the rest of the body through the blood out into each alveolus. That process is called oxygenation. So, these two processes are core to respiration. Any failure of any of these processes, for example, the failure of oxygenation or the failure of ventilation, will comprise what we know generally as respiratory failure. Now, it is important to note that there are two types of respiratory failure. The first is what we call as type 1 respiratory failure, and that refers primarily to a failure of oxygenation. There is then a type 2 respiratory failure, which is more a failure of ventilation. That means a failure to move air into and out of the lungs. And because these two processes are very different, the causes of these failures, type 1 or type 2 failures, are again very different. However, they do appear similar in many situations, but they are of a different cause that occur within a different time frame, and very often their treatment can be very different. Let us look at type 1 failure or oxygenation failure. In this situation, because of the difficulty in moving oxygen into the blood or moving carbon dioxide out of the blood into the alveolus, there are abnormalities that we can identify. It is important to note here that it is much more difficult to move oxygen than to move carbon dioxide. Carbon dioxide is a much easier molecule to move. And therefore, in oxygenation failure, the primary problem that we see is actually a difficulty in moving oxygen from the alveolus into the blood. And this results in a low partial pressure of oxygen in the blood, which is called hypoxemia. And this resulting hypoxemia will cause a compensatory mechanism in the body. The body will recognize that there is not enough oxygen, and therefore, in order to compensate, they will increase the respiratory rate. The patient will now start breathing faster. Now, as a result of this faster breathing, The carbon dioxide, which moves more easily through the alveolus, will now start getting washed out much more. And as a result, we note that patients with type 1 failures have a low partial pressure of oxygen and at the same time a low partial pressure of carbon dioxide, simply because the carbon dioxide is being washed out. And this is therefore called a hypoxemic respiratory failure, because the primary problem is with hypoxemia, and that is the difficulty in moving oxygen from the lungs to the blood. This is very often due to a mismatch, a VQ mismatch, or a shunt, or both. Now, a VQ mismatch occurs either because there's too much ventilation in areas that do not have enough perfusion, right? And this occurs very often because in some areas of the lungs there is a mismatch in the flow of the blood, or a mismatch in the amount of air that reaches that part, or a shunt, which means that some areas of the lungs the blood will flow right across without hitting any area of oxygenated alveolus. This happens in combination in situations like pneumonia, pulmonary edema, ARDS, COAD, and bronchiectasis. Clinically, we find that the patient has a low SpO2, a low PaO2, and very often a low PaCO2. And the primary problem being at the alveolus and the arteriolar border. The main finding is an increase in the AA gradient. In type 2 respiratory failure, sometimes called ventilation failure, the problem is very different. The problem here is primarily the difficulty in moving air from the outside into the lungs, or moving the air out of the lungs into the environment. This is identified by a problem of low PaO2, because we cannot get oxygen inside, and at the same time a high PaCO2, because we cannot breathe out enough carbon dioxide. And therefore this is also called primarily hypercapnic respiratory failure. The problem being difficulty in moving air into and out of the lungs. And this is often due to poor respiration, hypoventilation, or difficult breathing efforts. As example, in asthma, in opioid overdoses that lead to low respiratory rates, in severe brain injury that affects respiration, in muscle disorders that weaken the muscles of respiration, in poisonings or snake envenomations that paralyze these muscles. Our findings therefore are low SpO2, a low PaO2, and a high PaCO2. On the whole, the AA gradient often is also raised. So the causes of respiratory failure is not restricted to the lungs alone. It is important that whereas there are many causes, pulmonary causes of respiratory failure, there are many non-respiratory causes of respiratory failure. And this may include cardiac causes, for example, acute heart failure, acute valvular incompetence, cardiac tamponade, and so on. There may be obstructive flow problems, for example, tension pneumothorax. There may be muscular problems affecting breathing efforts, or CNS problems affecting regulation of breathing, poisoning, and toxicities that affect respiration. Very often, the causes are not immediately known. So, even though we do not know the causes, the initial treatment of these patients are very similar, and they come in a series of priorities. And the first priority in what all these patients, regardless of the cause, is to correct hypoxemia, because hypoxemia is the predominant cause of immediate death. And if we can correct it soon, then the risk of death is very much reduced. Only then do we look at the second priority, is to correct the underlying pathophysiology if we can identify it, and then we can look for and treat the underlying causes. Regardless of whatever the cause is, the initial treatment and the initial priorities are always done in every patient. The correction hypoxemia is aimed at giving supplemental oxygen to achieve a target of a PaO2 of more than 60 mm mercury, or if we use the pulse oximeter, a pulse oximeter reading of more than 90%. We do this by using the oxygen delivery devices. Depending on the patient's situation, we may start by giving low levels of oxygen first and then escalating, or by giving fairly high levels of oxygen and then decreasing. Whatever it is, we must quickly aim for a SpO2 of more than 90%. If we have given high levels of supplemental oxygen already, for example, if we have used a high flow non-rebreathing mask and maximum oxygen flows, and we are still not able to achieve the SpO2 of more than 90%, then it is time to give oxygen under pressure, and by using non-invasive ventilation, or if they're still not improving, by providing positive pressure ventilation after endotracheal intubation. Remember, oxygen supplementation or NIV itself will not work if the patient has poor respiratory efforts or is hypoventilating. What do you think is the recommended treatment in these situations? In patients with poor respiratory efforts or hypoventilation, or in patients with altered mental state, very often the difficulty is to bring air from the outside into the lungs, and this is a problem of ventilation, and therefore we have to intubate and provide ventilations, provide positive pressure ventilations. Generally speaking, we must do this in as safe a process as possible, because remember, these patients are already hypoxemic, and further hypoxemia may very rapidly worsen their situation or may even lead to cardiac arrest. Therefore, as a general target, if we were to provide positive pressure ventilation, we must pre-oxygenate as much as possible. We must ensure everything is well done to ensure high first pass success, to minimize apneic time, and we must calculate and maintain pre and post minute ventilation as we set ventilatory settings after we have intubated the patient. It is important to address all this properly to avoid the main problem that occurs in these patients, which is post-intubation arrest resulting from severe hypoxemia. In different diseases, the ventilatory settings may be different. In particular, for ARDS, we use a lung protective strategies, which is using a tidal volume of 6 ml per kilo of ideal weight. We try to keep the plateau pressures low, below 30 centimeters of water, using high PEEP to ensure oxygenation, and KIV positioning of the patient to improve VQ mismatch. In patients with obstructive lung diseases, a tidal volume of 6 ml per kilo of actual body weight, we slow down the respiratory rate to 8 to 12 per minute, and we use high inspiratory flow rates. These are a few further explanation notes for your use. Thank you.